we are learning much more about subsets, and there's still a long way for us to really understand the various subsets. Right now, we do understand the importance of RAS mutations. We're learning a lot more about BRAF mutations. We have studies targeting the BRAF pathway that includes BRAF, EGFR inhibitors and MEK inhibitors, plus minus chemotherapy, that are trying to improve the really bad outcomes that we see with BRAF mutated tumors. We also are seeing more and more studies addressing HER2 amplification. The subgroup of patients with 4% of patients with colon cancer have HER2 amplifications. That group does not seem to respond well to EGFR inhibitors, but dual HER2 inhibition seems to produce some significant responses. There are trials underway in that group. We have MSI high with significant responses to PD-1, PD-L1 inhibitors, perhaps a role for CTLA-4. I'm not clear yet on that. And we're starting to look at even smaller and smaller proportions of patients with colon cancer, whether those that have NTRK alterations, FGFR, MET, PIK3CA, and trying to understand how these different baskets are driven prognostically and whether we can use them as predictive biomarkers for target therapies. So I think the landscape is changing quite significantly. And then the CMS classification itself is starting to make its segue into mainstream clinical practice. And there's the BRAF-like group, for example, that will likely be the one that benefits the most from some form of immune therapy. Perhaps not PD-1 inhibitors directly, because we know those are not active in MSS, but likely some form of PD-1 plus another immunotherapy agents or a combination of other biologics and immune therapeutics.
Some of the more important biomarkers that we've learned a lot about, that we know about, of course, are the MSI high, hypermutated patients that benefit from immunotherapy. We've known about BRAF. There are a number of studies now in BRAF that are clearly showing a benefit with combination BRAF inhibitors, anti-EGFR therapy, as well as MEK inhibitors or irinotecan. Beyond that, HER2 is one of the more exciting emerging markers, where in HER2 amplified tumors, there appears to be a signal with anti-HER2 therapy in colorectal cancer that comprises approximately 3 to 4% of all metastatic colorectal patients.
In the next few years, I think we will see effort on additional biomarkers for later lines of colon cancer therapy and even earlier lines. Besides from microsatellite instability, which I think is a very clear biomarker for benefit of checkpoint inhibitors, there are others that are being looked at very aggressively. HER2, which is infrequent but occurs perhaps in 1 to 2% of KRAS wild-type colon cancer only, may be a useful biomarker, and early studies such as the Heracles trial with trastuzumab and lapatinib showed benefit in that group of patients. That studies have now been taken to the next level through cooperative group settings, trying to look at KRAS wild-type HER2 patients to see if there's benefit to an anti-HER2 drug. Additional studies are also being done in other biomarker subsets, which include looking at the CMS classifications, CMS 1 through 4, trying to see if any individual CMS subtype might be sensitive to an immunotherapeutic strategy, for example, or to additional strategies. We've seen here at this year's GI ASCO some more longer-term data with the combination of MEK inhibition and PD-L1 inhibition with atezolizumab, and that might be a subset of patients. And there's a lot of interest now in a group of drugs which are CEA bispecific antibodies, looking at which subsets of those patients might get benefit as well. So the next few years, we are hopeful and optimistic that a new series of biomarkers will emerge, which will allow us to treat these patients in a more directed fashion.